Good afternoon. Thank you for the opportunity to speak today. My name is Cassandra Smith, and I'm a licensed clinical social worker and board-approved clinical supervisor. I have been providing mental health and behavioral health services for close to 20 years. Currently, my agency provides specialized outpatient behavioral health services, amongst others. We have a specific focus in the treatment of patients who have experienced trauma and abuse. We are licensed by the state of Louisiana as a behavioral health provider, as well as nationally accredited by the Commission of Accreditation of Rehabilitation Facilities, or CARF. In spite of meeting all of the regulations and qualifications that allowed us to become licensed behavioral health Medicaid provider, we have been told we could not be contracted to provide these mental health services with 3 of the largest managed care organizations that manage Medicaid-funded services in Louisiana. Our agency has had to turn away close to 40 Medicaid consumers seeking mental health services because we are not enrolled with their assigned managed care organizations. We receive calls regularly to provide behavioral health services to Medicaid consumers that we must turn away. When attempting to contract with the managed care organizations, we were told that the networks were closed to behavioral health providers because, and I quote, network adequacy has been met. In other words, we have enough providers like you enrolled in our network. The relevant question, though, to pose is how network adequacy is established. As of today, the only standard to meet network adequacy is that a specialized behavioral health agency is within a 15 to 30 radius of the member. This does not give a true picture of access to care. Some questions still remain unanswered. Questions like, what is the wait time for an appointment with a provider within that radius? Are Medicaid clients satisfied with the quality of care of the providers within their radius? To put it plainly, I have more than 20 McDonald's within 15 miles of my home. One has slow service, one always makes a mistake with my order, and one has horrible customer service practices. The great thing is, if I'm not pleased with one, I can be serviced by another. The more choice I have as a consumer, the better. So the standard of network adequacy only shows that the network is adequate in theory and not actually measuring true access to care. Just this year, the National Council for Behavioral Health urged the Federal Centers for Medicare and Medicaid Services, or CMS, to strengthen federal network adequacy requirements. The National Council for Behavioral Health's public recommendations to CMS regarding network adequacy says states should establish 2 categories of network adequacy, which distinguish between those that are static, for example, time distance or provider to enrollee ratios, and those that permit real-time assessment of actual network performance. The MCO's current standards in Louisiana do not measure actual network performance and network adequacy. Opponents of this legislation will say that the network is oversaturated with Medicaid behavioral health providers. I would respectfully point out that they are wrong. If all of the currently licensed behavioral health providers, which to my knowledge is about 610 or something to that effect, if all of those providers were contracted with all 5 MCOs, the provider to member ratio would be on par with physicians. Aren't we striving to attain parity between mental health care and medical care? Ultimately, if a Medicaid consumer is not satisfied with their current provider, they should be able to choose any willing provider that is licensed, duly qualified, and willing to contract with that managed care organization. The current system, which has some MCOs closed to providers and others who are not, forces Medicaid members to navigate a longer than necessary complex maze, which may or may not lead them to quality mental health services. Currently, if a Medicaid patient contacts a provider that they are told accepts Medicaid for mental health treatment, they may be turned away if that provider is not contracted with their specific MCO. House Bill 409 will create ease of access to care by simplifying the system to ensure all LDH licensed and qualified providers are licensed and contracted to provide those services with MCOs. Continuity of care in all health care is critical, but particularly in mental health care. We are currently on the brink of potential changes that will determine the managed care organizations that will be chosen to contract with the state of Louisiana. However, this process has the potential to do immeasurable damage to the health and well-being of Medicaid members without the institution of House Bill 409. LDH has made it clear that they're selecting 4 MCOs rather than 5. What happens to Medicaid patients who are receiving mental health services by a provider who is not contracted with their newly assigned MCO? There have been no concrete plans made public about how the situation with potential dire circumstances will be handled. Another important factor is the current state of closed networks and how that has contributed to a direct and negative impact on small and minority-owned businesses. Their inability to enroll with the largest managed care organizations has forced many to reduce the services they offer and others to even close. Their closures have a larger impact on the community and stakeholders and their ability to ensure that those they serve receive all the services that they need. I have spoken with representatives from schools, court systems, and the like who have expressed to me how agency closures have affected their referral networks. In closing, let me summarize what House Bill 409 will change and what it will not change. House Bill 409 will change Medicaid and consumer freedom of choice for the better. It will allow a greater pool of qualified and licensed providers to choose from. House Bill 409 will change Medicaid consumer access to care for the better. If all licensed and qualified providers are contracted with all MCOs, Medicaid consumers can have a smooth and expedient access to the critical mental health care that they need. House Bill 409 will change Medicaid consumer continuity of care for the better. No Medicaid patient will be at risk for a delay or abrupt termination of services by their treating providers if all LDH and licensed qualified providers are enrolled and contracted with all MCOs. House Bill 409 will change the disruption of referral networks utilized by community stakeholders by preventing the closure and reduction of mental health services for the Medicaid population. House Bill 409 will not change any of the legislative, regulatory, or licensing requirements that are already established by the state of Louisiana Department of Health for becoming a behavioral health provider. House Bill 409 will not change those provider requirements to participate in a Medicaid managed care organization's network. They are currently already outlined in their provider contracts. That will not change. Quality measures set by MCOs still must be maintained by participating providers. So I hope that the information presented to you illustrates the need for your support in favor of House Bill 409. Thank you.
Y'all have anything to add? No, I wanted to come over and express my support. I'm co-author on this bill, and after many meetings with different providers out there, I thought it was necessary that we look at doing something. So I just wanted to come in and say that I am co-author on this bill with Representative Franklin, and I certainly support it wholeheartedly that we move this bill forward so that we can get a better grips on what's going on out there. So far as how MCOs are being managed and some of these providers are being kept out when they provide a service to our people and to those people, but yet and still some people are being squared. So I think something has to be done and we have to look at it.
Hi, and I would like to add...
Identify yourself, please.
My name is Shanara Pouncey. I am one of said providers. I do own a small business. We are licensed. And after going through that extensive and expensive process, we were just told by all but one of the MCOs, we're not contracting or credentialing new behavioral health providers, which, I mean, what would be the point in LDH collecting licensing fees if the MCOs are not going to be open to behavioral health providers?
Thank you. Other people who do not wish to speak but present and support: Ed Parker, AFSCME, the Ashley Pullitz, Louisiana AAP, Matthew Wallace, Easter Seals, Louisiana, Henry Pouncey III, behavioral health provider, Nick Gautreaux with Direct Solution Strategies, and Dr. Mark A. Pierre with the Kennedy Center. Jen Steele, Ms. Steele, would you come up to front, please? We had several cards in opposition to this, though I don't show any of them wanting to speak. Rodney Braxton of the Blue Cross and Blue Shield of Louisiana opposed. Daryl Cahoon, the Aetna. Danny Ford, the AmeriHealth Capitalist. Rachel Farmer of the United Health Group. Julie Vincent, AmeriHealth Caritas. Kathy Kleber with the Louisiana Medicaid MCO Association, Dickie Patterson with Healthy Blue, and Jesse McCormick, Aetna Better Health, all opposed to this bill. Please identify yourself and kind of explain what we got here.
Jen Steele, Medicaid Director, and I'm going to actually let my colleague take the lead.
Okay.
Hi, good morning. Karen Stubbs, Office of Behavioral Health, Louisiana Department of Health. Good morning. Thank you for having us. One of our, to put it pretty high level and brief, one of our concerns is that the bill as written seemingly requires us to contract to maintain open networks for providers who may have a quality of care concern, to either allow them entrance into the network or maintain them in the network when things such as credible allegations of fraud, waste, or abuse are present, or quality of care concerns have been identified. As written, it's a blanket open network to providers who wish to participate without any safeguards around quality of care of providers.
And I would add that there are federal regulations that prohibit us from including in our networks providers who have been excluded in terms of fraud, waste, and abuse, or who have concerns in that area. So, as written, it doesn't allow us to comply with federal law. Okay,
Representative Johnson.
I was just really wanting to get the department up here to ask them, I guess why, people are getting denied, but I guess you've answered that question. So.
Yes, there are some types of providers within this provider group that actually there was so much oversaturation. There's FNR, Facility Needs Review, so kind of a pre-screening before coming into the network.
I guess walk us through the process. So there's an application, I guess, for somebody to become a provider, and they pay a fee. I guess.
Yes, sir. So this particular bill, as written, applies to behavioral health providers, the behavioral health service providers. That includes several different types of providers. Your traditional mental health rehab providers, as they're known, but also this would include substance use providers, residential and outpatient. So a variety of provider types. An example of how I believe this may have come to fruition, we have on the type of provider type called MHR, mental health rehab provider. Last year there was a piece of legislation implementing a facility needs review. The network had really expanded, and so there was a piece of legislation that required that we institute an FNR, which is a process the department has through our licensing department on several different types of providers. It's not just for a certain behavioral health provider. That means before submitting their application for licensure by the department, they have to go through a committee and demonstrate an actual need. I can give an example of, we got applications saying there's not another provider type like this on my street. and that was an example of an argument as to why they should be let into the network. So it's kind of just a gateway, an initial screen to see if there really is a need for that provider type. Once you pass the FNR, the Facility Needs Review, and we have FNRs on several different provider types, even outside of the behavioral health field. Then you would go through licensure, and then and that's within the department. And then after licensure, you would proceed with contracting with one of the managed care companies. All of the managed care companies, their networks vary a little bit, and so you might get a contract with one or two managed care companies and not another one or two, especially if they're one of the bigger ones who's been around and they've got a pretty robust network already.
Okay.
Did that answer?
Right.
Representative Cox.
Excuse me. Did I hear correctly that managed care is making the decision whether these people can be put on the list or not?
No. So right now we have a...
Wait a minute. Yes or no?
No.
Then why are they here?
Right now there's a facility needs review, an FNR requirement that comes through the department first to determine a need in that community. And then it goes through licensing through the department. And once someone receives a license, then then that signals to the managed care companies that this person or entity is available for contracting.
Right. You guys give them a license.
Yes, sir.
Correct. All right. So I'm trying to work through this because managed care makes billions off of us. And I... help me, because I'm telling you, what I'm saying is what I read was that they make the, and what I heard was that they make the decision of whether they get on the list or not. And if that's true, then that's an atrocity. I mean, that they shouldn't be able to make that decision. Maybe I don't know what I'm talking about here, but can somebody correct me on that? Can they make that decision?
They make the decision, yes, within their network, not for licensing. That comes through.
Oh, I'm not talking about license. And I know you guys do what you have to do. And once it's gotten through you, then managed care can then go in and say, well, because Johnson here got a company, and why did I discriminate? Now, I understand you discriminate if somebody has a fraud, waste, and abuse. I'm not talking about those. So I hope nobody's here that had a fraud, waste, or abuse case. But anything else, it should be, I think we work on this free market, right? Free enterprise kind of thing. I mean, so I'm concerned about that because they should not be the control. They should not be doing this if they're doing this. Would you agree? Or is there a special comment on this thing? I don't understand. Give me the 5th grade version.
So I guess I'm a little confused about the different process steps and
if you're
the
confused,
licensure by the department, because that does the licensure.
I'm clear on that. I'm clear that you guys take them through the process, through the rigmarole. They do what they have to do, and then now I've gone through the licenses. I paid my fees, and then now here I am. I'm showing up with my piece of paper saying that I'm capable of doing this, and I've passed through the facility needs tests. I've done all the stuff, and now I can't get a contract because these people decide, managed care, decide that they can't have it. I don't understand that.
So I think the problem might be that
maybe I need managed care at the table.
That the way this is written, it's much broader. It requires a contract regardless of quality of care concerns with the provider, regardless if they're practicing or in the passive practice in compliance with clinical practice guidelines or grievance or appeals or grievance or complaints or fraud, waste, and abuse allegations, credible allegations, or inclusion on a provider exclusion list. It's written to just basically openly mandate contracting without any sort of safeguards for the providers coming in.
Okay. When that's kind of confusing to me because I don't. So tell me if managed care can make the decision whether or not that these people who are qualified by you can be put on the list.
They make the decision of who they contract with, yes.
And who gives them that authority? Us?
In two ways. After they've passed licensure, that's our stamp, and then through our contract, we give them authority to manage their networks.
So managing their network, that means that they don't necessarily, they can put whoever they want on there.
That's right.
Yes.
The contracting decision is theirs.
Well, why would somebody fill out an application in the first place and then they're not allowed to be put on there? Something's wrong with this. I mean, I love all you folks, and and everybody know I got a little bit of niche on managed care. I see my man back there, he tension up. But the bottom line is that to me, and I'm just the old country boy from up there in North Louisiana, but I do not understand how we can restrict people from trying to make a living. Because that's what it seems to me. And I'm not after, you guys got so much stuff going on there. After this over with, we need to come on and just talk about it. But I'm just don't understand that if they have that much flexibility that they can do that, then it would be one thing if I'm not qualified. So are these people being denied because they're not qualified?
I think in some cases, I think what Karen's trying to express is that in some cases there are concerns that are not explicitly fraud, waste, or abuse that are where there would be an interest in narrowing that network to not exclude folks who, again, if there's consistent quality of care concerns, if there's not evidence that they're providing the evidence-based practices. Again, you might have licensure, but it doesn't mean necessarily that, you're the best performing provider in the market. And so the plans have the flexibility to choose.
Yeah, I understand, Dr. Steele, but it seems as though also that I could be shut out because some other reason, and I'm not sure what that is. But to me, that if I should not be qualified if I can't, in other words, if I become a welder and I pass all the tests, I can qualify to go ask to get a welding job anywhere. It should be the same if you give a license to some of these folks, because otherwise they shouldn't have a license if they can't perform the duties or work. Mm-hmm. That's kind of how I've always had this throughout my little military and life career here with this thing. And I'm concerned that the companies can, even though I got a license, I can't do the work. So then you starve me out, and then I'm gone.
I think that a common comparison would be you got licensed contractors, licensed electricians, licensed, you might not choose to hire all of them, right? There might be some that have a better reputation than others. I think that's the basic principle here.
Well, I understand some may be performing better, but also I realize that sometimes people never get an opportunity to perform. And that's the problem where I have a problem at. I might be the best builder, but if I never get anybody to allow me to build, then the only way I can do it, I don't know how to do it. So what I'm saying is they shouldn't be denied the right if you give them a license. If they don't get a license, if you don't give them a license, there should be I'm just having a problem with managed care being able to do this without nobody saying that it's no big deal. I don't know if it's because you're not capable. I don't know if it's because it's a bias in some way, and I'm concerned. I'm greatly concerned about this because don't let me go and do all this work and then you squeeze me out. That would be difficult for me. Thank you, Mr. Chairman.
Thank you. Representative Turner.
Representative Cox, thanks for your comments. As a small business owner, I agree with you. And also as a small business owner, I'm looking at the sheer dollars this is going to cost the state and wondering if this is in the right committee, because I'm looking at 2020, it's going to another $12.56 million, and in 2023 it's 14.53. And after looking at that, I'm requesting we, without action, I recommend that we move this to appropriations.
Okay, we will take a vote on that in a moment, but we'll hold as we continue to have, if there are any other questions. In fact, I don't see any other questions right now. So, do y'all have anything else you'd like to add?
No, sir.
Okay. And y'all can come back to the table and kind of close.
Thank you.
Yes, sir.
Members of the committee, Mr. Chairman, members of the committee. Let me get something straight here, because I met with the department on several occasions, and we talked about the fact of those people who doesn't qualify through fraud and all of those types of things. This bill has nothing to do with that. This bill is saying about qualified providers. If they have committed fraud, if they are under audit, there are already rules in place to handle that. And I resent the fact that they came up here and said those things when it's not true. We had the discussion privately in my office. It's ridiculous for them to come here and make those kind of statements to you that are not factual, and they know it. This only applies to people who are qualified. There are rules in place, ladies and gentlemen, to protect that against those who would commit fraud, under audit, or not doing something right. This bill does not open it up to anything like that. As regarding to the fiscal note, that fiscal note was provided by them. Of course, they provided that information. That's the way they do when they want to do something other than what they should be doing. So they provided you a fiscal note that says that, oh, it's going to cost $12 million. But a lot of it is federal dollars that would be drawn down because these people are now able to provide service to our people. So that fiscal note, and I will certainly challenge that if it does go to appropriation, because that's not right. So we need to, and I ask you to take a strong look at this, look at what they told you, the facts, some of the things that they said that were not factual, and make a decision based on that. And I know she want to add some things to close it.
Thank you, Senator Price. I'm more than frustrated, and I think, unfortunately, some of the things I'm forced to say are just simply not true that were just stated. And I want to make some distinctions in the process she even explained. I'm not, and forgive me for saying she, but this has nothing to do with your prior process of licensure. When she mentioned a facility need review, that happens well before you're even offered the opportunity to license with LDH. So that has nothing to do with the process this bill is addressing. All of this just simply was put on the table and it clouded the issue because it has nothing to do with this. We're talking about you have gotten a facility need review, you've put in your application, you've met all the criteria, you've done everything that's required. And I might state that the MCO contracts are very clear about what it requires to be in their network. She mentioned the exclusionary list. I'm very familiar with that. That's if you have ever committed some type of fraudulent activity. All of that has to be checked before they contract with you. If you sign their contract, that contract states that if you do not abide by those qualifications, your contract can be, in effect, terminated. None of that changes. So my concern is we have tried to make the issue something that it's not. And furthermore, I just think that the reality is that, and I'm not a numbers person. I'm a social worker. I've been a therapist for 15, 20 years, but I have common sense. If they're not treated by me, the member will be treated by someone else. So when you're talking about the fiscal note, I saw an underline in that fiscal note that talked about you cannot determine the amount. So I'm really confused about how they can determine amount, but we really can't determine an amount. If that person is seeking mental health care, whether they seek that care with me or another provider, those funds will be used. So what you're trying to do is say that 17 providers, because that's the number, I don't even know if that number is accurate, I don't know where that number came from, are going to cost the state this amount of dollars. You can't anticipate how much service I'm going to provide. That's a number that's not quantifiable. So the MCOs are paid per member per month. These are federal dollars. Enrolling individuals who you've already said are qualified and licensed will not change that. And there's one last thing that I want to say, because she mentioned, and I'm sorry, I lost my train of thought. I got so frustrated. She mentioned, I believe it's with the contracting. They certainly make the decision if they contract with you, but how do you determine, and this is a question I will pose for you all, how do you determine if a provider has committed fraud if they've never worked for you? So one has nothing to do with the other. We're talking about if they're in an audit process or they're being investigated for fraud, all of that's already legislated. And I think somebody else mentioned there are bad apples in every group. But I don't think we're looking at the big picture and how these decisions are affecting the Medicaid members. First of all, as a provider, this is not a win for me other than the fact that I get to keep doing what I've been doing for 20 years and not have to worry about it. But at the end of the day, more competition, somebody mentioned this is a free market, is better for the consumer. And if we're really talking about raising the level of quality, that forces you to raise the level of quality. And what I resent is that the allegation is that we were shut out of the network because there was some issue or quality of care. Now, for me, it may have been there was some resentment that I challenged them, and I'm going to put that frankly. But we met all of the qualifications. We have all of what's required. My record is stellar. I've never had an allegation of any kind. So that statement even being made is very problematic, particularly when we've had 3 or 4 different reasons thrown at us about why there was problems with this particular bill. So I would just challenge you to look beyond all of the cloudiness. This bill is very simple. If you license me, I'm qualified. It allow me to provide the service. It changes nothing about qualifications, criteria, and frankly, it really doesn't change anything about money.
Thank you, ma'am.
Thank you.
Representative Jackson, do you have a question or
Just a question. I keep hearing about this, Senator, about this note. Is this something that just was dropped on you, or did it go through the process in the Senate?
This is
a House bill.
It's a House bill.
It's a House bill.
Oh, you're presenting somebody else's bill.
Right.
So you're just receiving
I'm a
this?
co-author on this bill.
Okay.
Yeah, I received it this morning.
So just like Tanner, you're just receiving a note?
Yes.
Okay.
Okay. We have a motion by Representative Turner to report without action to the Committee on Appropriations. Okay, Representative Jackson.
I'm going to offer a substitute motion with explanation. We've been passing bills out of each committee, and the clerk determines whether or not the note on that bill or refers it. So I'm going to make a substitute motion to report the bill favorably, and with the understanding that if this bill goes to the floor with a note that's not worked out, it's going to go to appropriations automatically.
Okay.
All of them do.
You heard the substitute motion.
And I love Mr. Turner. Dr. Turner.
The motion is to report
Want me to call your
favorably. To report favorably.
As a friend, strictly platonic.
This still could, of course, be sent to appropriations.
That's what I'm
as
saying,
often
and I
as
just
can
wanted to
be.
make that clarification that all bills that have a note over certain amounts do a referral. And I didn't want to treat the senator any differently, because Mr. Turner, when you get to the Senate and you treat them differently, they treat you very egregiously. I've went through that. I've gone through that.
Okay, does everybody understand the motion? The substitute motion is to report favorably, and it may or may not go to appropriations. That will be determined on the House floor.
Determines whether or not he had some
Is there any objection to that motion? Reporting it favorably under those conditions. Without objection, we'll report favorably under those conditions. Thank you.
Thank you, Mr. Chairman, members of the committee.
Thank you.
You better ask him. They'll screw the hell out of you in the Senate one.
The last bill of the day,
Look, they did it to me.
House Bill 358.
This what I'm saying, but
Woman right there is one of the most corrupt people there is. She went to DHA, she testified in the Senate last year, lied. DHA changed all of their policies. She still lied.
Representative James.
She's somebody from Baton Rouge. Now they banned her, so now she's trying to come with a law that says you must let everybody in. She's bad for business.
And Drew is going to call it in.